嚟播啲片嚟睇下。
好，大家下來。
Experience every emotion in one place and more. Immerse in all with 360 Hong Kong moments.
Hong Kong is a dynamic, wonderful, safe environment. There's no reason not to come here as either a tourist or as a business traveler or as an attendee at an event.
对于内地客户来说，它不像海外，香港是非常重要的一个出口，在亚洲是一个比较重要的一个金融地位，是非常适合在香港举办这样的大型展会。
So Hong Kong has so much to offer. You have the heartbeat of an international financial city, but you also have beautiful mountains and beaches a stone's throw away.
There is a very strong business community, and the whole Bay Area initiative is definitely very important to position even more Hong Kong as a center for business.
Hong Kong is a very central place where everybody comes so easily to Hong Kong, and it's an excellent place of people meeting together.
Hong Kong
is the world's
meeting place.
The world meeting place.
Mr. Nelson, Mr. Sugianto from Paris sent his greeting and apologize for not being able to attend the meeting because he's still on board, still on the plane for business trip. Yeah, so he wished for a success conference for tonight.
Thank you.
You're welcome.
I think next is CPD. How we introduce in ISRRT Congress in Hong Kong 2024 for everybody. Yeah. I think next is CPD. We have one slide for introduce ISRT 2024 in Hong Kong.
I have a last slide in after the the program. I have a slide for the promotions of the next year ISRRT. for
Yes.
2024. Yeah. Yeah,
Yeah,
for
thank you.
all the members. Yeah. Thank
Yes. Okay. Thank you.
you. Yeah. Hello, Cora.
Hi, Cora。
Hi。
Thank you。阿基哥去咗泰國喎，好似係
今日我代表啦。
我見到佢好似去咗泰國。咦，咁我哋係介紹阿 Cora 定係介紹阿基哥？介紹阿 Cora 得啦，係嘛
Cora 啦，係啦，好改翻。
阿 Cora 係 chairman 啊嘛，係咪叫 chair？
係啊，chairman。
Chairman of MRTA。
The chairman of MRTA 係啊。
OK。
唔該。
好。
Experience every emotion in one place and more. Immerse in all with 360 Hong Kong moments.
Hong Kong is a dynamic, wonderful, safe environment. There's no reason not to come here as either a tourist or as a business traveler or as an attendee at an event.
对于内地客户来说，它不像海外，香港是非常重要的一个出口，在亚洲是一个比较重要的一个金融地位，是非常适合在香港举办这样的大型展会的。
So Hong Kong has so much to offer. You have the heartbeat of an international financial city, but you also have beautiful mountains and beaches a stone's throw away.
There is a very strong business community, and the whole Bay Area initiative is definitely very important to position even more Hong Kong as a center for business.
Hong Kong is a very central place where everybody comes so easily to Hong Kong, and it's an excellent place of people meeting together.
Hong Kong
is the world's
meeting place.
The world meeting place.
Hello, everyone. We will start the program sharply on 6:30. Is it okay?
Yes.
Okay,
Yeah.
thank you. Okay, 5 minutes later.
Very good
we
morning.
sharply start. Yeah.
Hi, very good evening, all.
Hello.
Hello.
Hello. Namaste. Namaste.
Oh, have a nice day.
Thank you.
Welcome.
Thank you. Thank you, sir.
Yeah, welcome everyone. Yeah.
咁得意嘅呢個畫面，幾有趣。
係啊，佢有一嚿嘅呢個。
係咩？
係，喺右上角阿 Will 搞嘅，好得意嘅。
You know, everyone sitting in the hall, just like
a lecture room.
A lecture room, yes.
Yeah.
The setting is cool. It's like we are watching a movie or in the theater.
Yeah.
True.
Before we start, we can take a photo for group photo. Do everyone open your video camera first, okay? Are you okay?
Yes.
We take a photo first. Yeah, group photo. Yeah. Will, are you ready?
Yeah.
Okay, everyone. So 1, 2, 3, smile.
Okay.
Okay, thank you.
Hi, Miss Chan Lai Kwan.
Thank you.
Welcome.
Thank you.
Thank you.
Hi, Miss Chen.
Hi, everybody. Good
Hi.
evening.
Hello.
Yeah,
Hello.
nice to see you.
Everything is fine now.
Okay, that's great.
Very good evening to all.
Okay. Okay, we start today the program, okay?
Yes.
Okay. Good evening, everyone. Welcome to 28th Asia CPD program, which held by Hong Kong Radiographers Association. I'm TM, who is the moderator of today's program. Before starting Asia CPD program, let me introduce these different countries' CPD Asia leaders. Mr. Jin Sugiyato, from President of Indonesian Society of Radiographers. Ms. Koram, hello.
Hello.
Welcome to join. Ms. Koram, for Chairman of Macau Radiological Technologist Association. Hello, Cora.
Hello. Nice to meet you here.
Nice to meet you. And Mr. Kim Mo-tin, of the President of the Myanmar Society of Medical Radiation Technologists. And the panelists of the Miss Yin Wan O and Miss Yin Yin Ten, is there here? Okay. Following is the Mr. Rolando Benitez, of the President of Philippines Association Radiologic Technologists. Okay. Next one is the Mr. Van Ngoc Thai, of the President of Vietnam Association of Radiological Technologists. Hello.
Yeah, good evening, everybody.
Yeah, welcome to join. Hello.
Yes.
Ms. Sophia Ni, of the President of Association of Cambodian Radiologic Technologists. Hello. Okay. And
good evening, everyone, and all praise
hello.
you again.
Hello, Sophia.
Yes.
Welcome to join. Yeah. And Mr. Van Schuppen Nelson, from President of Hong Kong Radiographers Association. Hello, Nelson.
Welcome.
Nice to meet you. Good evening. And Mr. Zhong Yun To, from the President of Taiwan Association of Medical Radiation Technologists. Hello. Okay. Next is Ms. Dennis Zhong, of the President of Singapore Society of Radiographers. Oh, and the next one is Ms. Sawang Masit, of the President of Malaysian Society Radiographers. Hello? Okay. Okay, next one is Mr. Siva Kumar of the President of Indian Society of Radiological Technologists. Hello? Good evening.
Namaste, namaste.
Hello.
Good evening to all. Pleasure in meeting you all today at this great program. Thank you. All the best for the today's CME event, CPD.
Okay, welcome. And
thank you. Thank you.
Thank you. And Mr. Mohammed Abdel Ghani of the Vice President of the Palestinian Association of Medical Radiation Technologists. Hello? Okay. Next one is the Mr. Kazuhiko Ueda from the President of the Japan Association's Radiological Technologists. Okay. Welcome everyone. Welcome. Hello. Okay. Now I invite Hong Kong Radiographers Association Chairman Mr. Nelson Wentz for the opening speech. Welcome, Mr. Nelson.
Thank you, Mr. On behalf of Hong Kong Radiographers Association, and thank you to each and every one of you for being here with us this evening. I'm also delighted to welcome all of the members from different Asian Radiological Technologists Society for this 28th Asian CPD program. And we do have today's topic is smart radiology, and we have 4 different topics, and we do all you enjoy the lectures this evening. Thank you very much.
Thank you, Chairman. Now we start today's Asia CPD program. The main theme of today's Asia CPD program is smart radiology. This is the hot topic in recent years. We are great to invite 4 speakers for today's topics. Please enjoy it.
Let me introduce the first speaker, Dr. Chris Ma from Bayer Healthcare Limited. Dr. Ma currently is a regional medical lead Asian Pacific of Radiology in Bayer Company. He has a rich experience in medical affairs such as liver hepatitis and heart failure. He received both bachelor and master degree in National Yangming University from the Department of Biomedical Imaging and Radiological Science and Institute of the Biopharmaceutical Science, respectively. He received a PhD in molecular medicine in Academie Sinica and National Yangming University. Today, his presentation topic is updated ACR guidelines and evidence on contrast safety. Welcome and give applause to Dr. Ma.
Thank you for the very kind introduction. And good afternoon, ladies and gentlemen. It is very honored to be the speaker in this very successful and wonderful meeting. My name is Chris. I'm the regional medical lead from Bayer APAC Radiology. And this is my disclaimer. So today I will introduce the updated information in ACR guideline on contrast media from 2021 and 2023. And I will discuss some common questions regarding the safety of contrast media in clinical practice. And all the answers and recommendations are based on guideline recommendations and published evidence. So first of all, this is the summaries of overall updates in ACR from 2021 to this year. In 2021, there are 3 chapters update, including Chapter 5 for fasting, and Chapter 10 for post-contrast acute kidney injury, and Chapter 16 for nephrogenic systemic fibrosis. And in 2022, 2 main chapters update are in the extravasations and also in the pregnancy screening statement for gadolinium-based contrast agents. For this year, the main updates is in nephrogenic systemic fibrosis regarding the eGFR calculations for the adult patients. So I will go into more detailed information for each update. First of all is the fasting update in 2021. Previously, some practice will request patient to fast before the intravascular contrast media administration to reduce the possibility of vomiting, nausea, and aspiration pneumonia. However, the modern contrast media for CT and MRI have much lower risk of vomiting compared to the contrast media used previously. And also, based on the evidence, there is no case of aspiration is attributable to the contrast media used recently. And also, there is no preventive effect of pre-fasting on the risk of vomiting and also nausea and aspiration. So based on the evidence, it is the first time in 2021 that ACR guideline include a new chapter for fasting and also recommended that it is not required before the routine intravenous contrast media administration. And the next update in 2021 is in chapter 10 regarding the terminology alteration. So first of all is the terminology alteration for contrast-associated acute kidney injury. Previously, it is used as post-contrast acute kidney injury, and now it is changed to contrast-associated acute kidney injury, which may occur regardless of whether the contrast media was the cause of renal function deterioration. So it's a correlative diagnosis. And for the contrast-induced nephropathy, it was changed to contrast-induced acute kidney injuries, which describe a certain renal function deterioration due to the contrast media administration. So it's a causative diagnosis terms. And the chapter title in chapter 10 was also changed accordingly. And another update in this chapter in that year is the indication and protocol of volume expansion, which is the major preventive action to mitigate the risk of contrast-associated acute kidney injury. And in 2021, the ACR guideline includes the indication for volume expansion that it is indicated in patients with acute kidney injury and also in patients with severe kidney disease. And for patients with border eGFR value around 30 to 44 milliliter per minute, if the patients are in the high-risk situation, then the volume expansion may be considered based on the prescriber's decisions and monitored. And also for the protocol, there's more specific information in the 2021 version. For the recommended fluid, it is recommended to use the isotonic fluid such as 0.9% normal saline. And for the protocol, it is recommended to initiate 1 hour before the contrast procedures and continue 3 to 12 hours after the exam. And for the dose, it may be used fixed volume or weight-based volume with 1 to 3 milliliter per kilogram per hour. And for the statement of oral hydration, it is changed that it is not well studied in patients with eGFR less than 30 and also in patients with acute kidney injury. And regarding the medical prevention of contrast-associated acute kidney injury, for the use of N-acetylcysteine, in 2021, it is changed to a more concrete recommendation that it is not recommended due to its not effective compared to placebo. And also for the sodium bicarbonate, it is not preferred because the efficacy is similar to the normal saline, but it requires additional compounding from the pharmacist. And the final update in this chapter is regarding the renal dialysis patient and the use of iodinated contrast media. So previously, urgent dialysis is only suggested in patients receiving large volume of contrast or patient with substantial underlying cardiac dysfunction. However, there's no convincing evidence demonstrating the benefit of prophylactic dialysis on the renal function. So in 2021, there are two main updates in this session. First of all is for patients on dialysis, but making urine around 100 milliliter per day. For this patient, they should be treated as high-risk patient and considered non-anuric to avoid converting oliguric patients to anuric patients. And the second update is that acute renal dialysis and renal replacement therapy should not be initiated solely because of iodinated contrast median administration because of the risk, cost, and also lack of proven benefit. And the final update in 2021 is regarding the chapter of nephrogenic systemic fibrosis. For the outpatient who may receiving group 1 or group 3 gadolinium-based contrast agents, they should be screened for factors that may be associated with renal function impairment. So in 2021, the ACR guideline modified the list of risk factors for identifying the patient with possible renal insufficiency. For the history of renal disease, the history CKD or AKI is included, and hypertension is removed due to large false positive rate, and diabetes is set as optional risk factors. And in the meantime, for patients with ESRD on chronic dialysis, there is an additional and specific statement update from ACR with National Kidney Foundation in 2021 version, that in patients who are already on dialysis, performing GBCA enhanced MRI before dialysis if clinically feasible. And also dialysis should not be initiated and rescheduled in patients receiving group 2 agents due to very low risk of nephrogenic systemic fibrosis. And next, I'm going to introduce the update in 2022. The first one is the extravasations of contrast media. So in 2022 version, in this chapter of extravasation, there is an updated recommendation with the strength of evidence provided. And overall, the focus on the cost of extravasation in terms of iodinated contrast media has shifted to the viscosity, meaning that the frequency is more common in patients receiving more viscous contrast media. And also several recommendations were made to minimize the risk, including using angel catheter rather than butterfly needles, performing meticulous intravenous catheter insertion, and carefully securing and inserter catheters. And also there's a note for the central venous catheters and PICC that these catheters should be certified and also provide the flow rate limit information if they are used for the power injection of contrast media. And finally, in the 2022, there is a Q&A format in this extravasation chapter to discuss the very crucial questions regarding extravasation, including how to minimize the risk and also how to manage when it has happened. And the next update in 2022 is regarding the gadolinium pregnancy screening statement. Because a retrospective study notified a risk of mortality and adverse events in the offspring after GBCA exposure during their pregnancy. So the ACR committee recommends to avoid routine administration of GBCA to the pregnant patients unless there is significant clinical benefit that outweighs the unknown risk. And also they remind that a hospital should include a more vigilant screening protocol, as there is a study noticed an increased prevalence of gadolinium-based contrast agent administration during the first trimester. And women with childbearing age should also be informed regarding the risk of fetal GBCA exposure. And finally, for this year, the only update is in the eGFR calculation that race is no longer exists in the equation, only creatinine, age, and sex are in the calculation. And next, as we'll discuss some common questions in patient in practice using a question and answer format. So first of all is, what is the consideration for patient with risk of adverse reaction, as there are several factors are identified for the adverse reaction after contrast exposure. In guidelines, several strategies are recommended to minimize the risk. First of all is the pre-medications. In this part, oral pre-medications is preferable to IV route in most of the settings. And although the efficacy duration is unknown, most of the study demonstrating that the efficacy duration of 4 to 5 hours is might be efficacious. And also there is no evidence supporting the duration of less than 2 hours currently. And the additional administration of antihistamine may help reduce several symptoms. And regarding the patients with previous allergic-like or unknown type of contrast reaction, it may recommend it to change the contrast media with the same class, which may help reduce the possibility of subsequent contrast reactions. And for the pre-testing, for the intradermal skin testing or testing injection, it is not recommended because it has not been shown to be useful in minimizing the reaction risk. And next, let's delve into the more specific recommendation from guideline regarding the pre-medications. First of all is the indications. So for the indications of 12 to 13 hours pre-medication by oral, it is indicated in all patients and in patients with non-history of allergic-like or unknown type contrast reaction. And for the inpatient, it should be noted that the use of oral pre-medication should not delay the patient diagnosis and also the patient treatment. And for the accelerated IV pre-medication, it is indicated for our patient with non-allergic-like history, but it has not been pre-medicated and the schedule cannot be easily rescheduled. And for inpatient, the accelerated IV pre-medication can be considered when the oral pre-medication is anticipated to delay the patient care or delay the patient treatment. And regarding the specific regimen for the pre-medication, for oral pre-medication, it is basically corticosteroid plus antihistamine. For the corticosteroid, there are two regimens mentioned in the ACR guideline. The first one is prednisone-based at a dose of 50 mg by mouth at 13 hours, 7 hours, and 1 hour before contrast exposure, and then with antihistamine 1 hour before the contrast administration. And for the methylprednisone-based at a dose of 32 mg by mouth at 12 hours and 2 hours before the exams, and also with antihistamine optional in 1 hour before the contrast exposure. And if the patient cannot take any oral medication, then for the first option, it may be replaced with 200 mg hydrocortisone IV for each dose of oral prednisone. And although there's no studies formally compare these two regimens, they are considered equally effective in the guideline. And for the regimen of accelerated IV pre-medication, there are 3 regimens mentioned in the ACR guideline in the decreasing order of preference. So the first preferred regimen for IV pre-medication is methylprednisone or hydrocortisone, injected immediately and then every 4 hours, and also with antihistamine 1 hour before the contrast exposure. The second regimen is dexamethasone, which may also be helpful if the patient is allergic to the first option, and the dosing duration and also the usage of antihistamine is similar to the first option. And the next option is methylprednisone and hydrocortisone, and also antihistamine, but 1 hour before contrast agent. But please note that this regimen is actually not evidence-based and should only be considered in an emergent situation with no other options. So next, I would like to discuss the renal safety of iodinated contrast media. And first of all, because in guideline, it is not recommended to acquire the renal function information before intravenous iodinated contrast media for all the patients. So which factor can be used to identify the patient may warrant further renal function assessment. So according to the ACR guideline, there are several risk factors, including personal history of renal disease, including non-chronic kidney disease and a history of acute kidney injury, dialysis, patient receiving kidney surgery, and patient receiving ablation, or patient with albuminuria. And the diabetes is an optional factor, and another risk factor is diabetic patients receiving metformin or metformin-containing drug combinations. And how about for patients with baseline medications? It is necessary to withhold certain medications to further decrease the risk of kidney injuries. So the recommendation from guideline is actually based on the patient's renal function, that in patients with AKI or eGFR less than 30, then it may be sensible to withhold some non-essential but potentially nephrotoxic medications for 24 to 48 hours and continue to be withheld for 48 hours after the exposure. But if the contrast-associated acute kidney injury already developed, then this non-essential medication should be continued be withheld until the kidney function has recovered. Another question about the baseline medication is metformin. Does the patient need to stop metformin before they receive the contrast media? So first of all, we should know that metformin doesn't really increase the risk of post-contrast acute kidney injury. And the most significant adverse event of metformin is the development of metformin-associated lactic acidosis. Because metformin is also excreted by kidney, so the renal insufficiency is the major consideration for the risk of increasing blood lactate levels due to decreased metformin excretion. So the recommendation regarding the patient taking metformin should be based on the renal function, and it is separated into two categories in ACR guideline. The first category is patient with no evidence of acute kidney injury and with eGFR higher than 30 milliliter per minute. For this patient, there is no need to discontinue metformin at the time and before and after the contrast media exposure. And for the category 2, in patient with acute kidney injury or have a severe chronic kidney disease, this patient, because there is potential concern of increasing blood lactate due to further renal function worsening. So it is recommended to stop metformin before or at the time of the procedure and continue to withhold for 48 hours after the contrast administrations. And patient can reinitiate the metformin after the renal function has been evaluated and found to be normal. The final common question is, how about the patient need the repeat scan? How long should 2 injections be apart? So from the European contrast guideline, it is based on the patient's baseline renal function as well. For patient with eGFR higher than 30 milliliter per minute, it is recommended that the time between 2 injections be 4 hours apart for both ICM and GBCA's injection. And also for patients requiring to receive the ICM and GBCA at the same day. And for patient with eGFR less than 30 or patient on dialysis, it is recommended to be 48 hours apart for ICM and for 7 days apart for GBCA and 7 days apart for patient who needs iodinated contrast media and also the gadolinium-based contrast agents. So the final question I want to discuss on the renal safety regarding the iodinated contrast media is the comparison between low osmolar contrast media and iso-osmolar contrast media. Currently in practice, the most commonly used is non-ionic contrast media. And there are several brands in the non-ionic low osmolar contrast media, but there are only one brand, iodaxanol, which is Visipec, in the non-ionic iso-osmolar contrast media. And although there's another low osmolar contrast media, iosaglate, but because it is ionic, so it only exists in few markets currently. And there are some debates regarding this comparison with some histories. In 2007, the American PCI guideline for the CKD patient receiving angiography, there is a recommendation preferring iso-osmolar contrast media based on the previous evidence. However, if you look at the further reference in the guideline for the previous studies comparing iso-osmolar contrast media and low osmolar contrast media on renal safety, most of the low osmolar contrast media used in the studies are iosaglate or another low osmolar contrast media, iohexol, which is Omipec. But there are more and more clinical studies comparing different low osmolar contrast media with iodaxanols. So this table lists the studies comparing iopromide, the Ultravis, versus iodaxanol in both intra-arterial or intravenous administration. And the enrolled patients are with different ranges of renal function, and the CIN definition used in the studies are similar. So for the results on the right panel, you can see most of the studies demonstrate that there's no significant difference regarding the risk of contrast-induced nephropathy between iodaxanol and iopromide. And also there are 3 large-scale meta-analyses in 2009 and 2010, also comparing iodaxanol with different low osmolar contrast agents on the incidence of contrast-induced nephropathy. So for these studies, enrolling patients receiving different low osmolar contrast agents, The results all show that there is no difference between iodaxonil with NLOCM except for iohexol and iosaglate, which the CIN risk is higher compared to iodaxonil. And I might have more attention in the study of form meta-analysis in 2010. If we further look at the subgroup analysis table, we can see if the comparison is made between iodaxonil and iohexol, then the CIN risk is significantly higher in patients receiving iohexol. But if the authors compare the CIN risk between iodaxonil versus other low osmolar contrast agents, then the CIN risks are comparable between these two types of contrast. So based on the increasing evidence, from 2009, the American PCR guideline recommended both iso-osmolar contrast agent and low osmolar contrast agent, except iohexol and iosaglate are indicated in patients with chronic kidney disease undergoing angiography. And furthermore, in 2011, the recommendation preferring iso-osmolar contrast agent was completely deleted from the guideline. So in the updated contrast media or cardiovascular guideline from United States and Europe, the recommendations on the choice of iodinated contrast media do not state any preference between iso-osmolar contrast agent and low osmolar contrast agent regarding the renal safety. And how about in some high-risk populations, such as patients with diabetes? Is there a difference between these two types of contrast on the renal safety? So there is some meta-analysis in 2018 analyzing the patient with diabetes and received different contrast media. And in total, there are 12 studies with total around 3,000 patients were included. And patients receiving low osmolar contrast agent were given iohexol, iopamidol, iopropamide, ioversol, as well as the ionic dimer iosaglate. And similar to the previous results, in the upper panel, you can see the risk of contrast-induced nephropathy is only significantly higher if the comparison is made between iodaxonil and iohexol. And in the lower panel, if the comparison is made between iodaxonil with iopropamide, then the CIN risk is actually comparable. And finally, I would like to share a recent update for this topic regarding the renal safety of low osmolar contrast media versus iso-osmolar contrast media. So it's a propensity score study from Korea to compare the contrast-induced acute kidney injury risk between these two types of contrast in 2022. And in this study, the author enrolled patients receiving a coronary angiography and PCI. And the contrast used for low osmolar contrast agents are iopropamide and iopamidol. And for the iso-osmolar contrast agent, the contrast media was iodaxonil. And the primary endpoint is contrast-induced acute kidney injury. So after propensity score matching, from the left-hand side, you can see there are around 2,200 patients in both groups. And in the right panel, you can see the baseline characteristic that all the factors are actually comparable between these two groups after propensity score matching. From the results, the incidence of contrast-induced acute kidney injury between low osmolar contrast agent and iso-osmolar contrast agents groups after propensity score matching, the difference is not statistically significant. And also the same scenario can be applied to the subgroup analysis stratified by other variables, including age, gender, comorbidity, and also the baseline factors. And there are several factors actually being identified in this cohort, including pre-existing chronic kidney disease, high volume of contrast, anemia, use of ROS blockers, and dehydrations. And these factors are also identified in several studies and also be mentioned in the ACR guidelines. So in summary for this topic, there is no difference between iso-osmolar contrast agent and low osmolar contrast agent regarding the renal safety based on the published evidence and also based on the guideline recommendations, except for certain contrast media demonstrated by some studies, including iosaglate or iohexol. And we may need to pay more attention on the patient baseline factors, such as baseline chronic kidney disease, the volume of contrast, and the baseline medications. which are identified in several cohorts and also mentioned in many guidelines. With that, this is my last slide. Thank you very much. And also thanks again for the invitation from HKRA.
Thank you, Dr. Ma. And okay, let me introduce the second speaker, Professor Zhang Yongping from Field Imaging Medical Limited. Professor Zhang is currently the chair professor of Biomedical Engineering of Department of Biomedical Engineering in the Hong Kong Polytechnic University. And he is also the director of the Research Institute for Smart Aging and director of the Jockey Cup Smart Aging Hub. He received the Bachelor of Science and Master in Engineering in Electronics and Information Engineering from the University of Science and Technology of China. He received a PhD degree in the Biomedical Engineering from the Hong Kong Polytechnic University in 1997. After a postdoctoral fellowship at the University of Windsor, Canada, he joined the PolyU as an assistant professor and was promoted to the professor in 2008 and chair professor in 2019, respectively. He was the associate director of the Research Institute of Innovative Products in PolyU from 2008 to 2010. He served as a founding head of the Department of Biomedical Engineering during 2012 to 2020. Professor Zhang made research interests include biomedical ultrasound and smart aging technologies. He was rated as a top 2% citation scholar in the area of AI and image processing in the survey conducted by Stanford University in 2021 and 2022. He published over 290 journals, papers, and wrote 2 books. A number of technologies invented by his team have been successfully commercialized, including ScolioScan, which won many international and local awards. Professor Zhang is a senior member of Institute of Electrical and Electronics Engineers, a fellow of Hong Kong Institute of Engineers, past secretary of the World Association of Chinese Biomedical Engineers, past chair of the Biomedical Engineer Division of Hong Kong IE, and honors advisor of Hong Kong Federation of Senior Citizens Industry and Hong Kong Medical and Healthcare Device Industry Association. He also served as a president of the Guangdong, Hong Kong, Macau chapters of the International Society of Gerotechnology. He has served as an associate editor and editorial board members for the same leading journals in the fields. Today, his presentation topic is ScolioScan, 3D ultrasound imaging with AI and scoliosis assessment. Welcome and give a big hand to Professor Zhang.
Okay, thank you so much, Chairman. I'm really sorry to give you such a long introduction. Yeah. Thank you for reading it. Also, thanks to Hong Kong Radiographer Association. This is really my great honor to share with you some of our work. As our chairman just introduced, I'm from the PolyU Biomedical Engineering Department. But actually, before 2012, we are in the Department of Informatics and in Department of Health Technology and Informatics. So that department actually was established in 2006 when 3 groups of colleagues and students combined. One is a radiographer. Originally, many of you actually graduated at that time in optometry and radiography. Okay, so in 2006 we combined together with the medical laboratory science. At that time is in school of at that time is Department of Nursing. Okay, so we are from name is Jockey Club Rehabilitation Engineering Center. So we merged into a department, and that is in the department the Faculty of Health and Social Science. And in 2012. actually we separated from that department and moved to engineering faculty. So this is a little bit history for some of you. So actually I taught some class for some of you, okay, because I taught radiographer students, master students. So today I would like to introduce you in some way a sharing, okay, because today we have two big companies, one from China, another one for overseas, United Imaging and Canon. So for us, this is a quite small company, but it is unique because it is invented in Hong Kong and grown in Hong Kong. So this technique using ultrasound, for some reason, I have been working in ultrasound for almost 30 years. Okay, so recently I also participated in, I see the timer does not start, so maybe I can have more time. Okay, let me, so quite surprisingly, even you may not see, even you are working in radiographer department, but I have not seen so many ultrasound devices. This is the toys that we have since 2001 when I first became the assistant professor in PolyU. And you can see we have $10 million Hong Kong dollar devices on the up right corner, and that is for animal. And we can have very small devices, very cheap devices, and many devices actually here is different from what we are using because we can access the raw data, radio frequency data. This because of that, we can do a lot of research. So this is slightly different from you. But anyhow, we are proud to have all this. And my team has been mainly working on 3 areas. And we are going to have the third book. Actually, now we are working with Springer, supposed to be completing next year or the year after. So the first and also my earliest one, starting from my PhD in PolyU, is the elasticity imaging and the measurement. And later on, I'm mainly working on 3D ultrasound, and this is a leader to this device that I'm going to introduce. And we are very, very happy that the telefield medical imaging want to bring it to the market. So this is why many things I can share, because really from a research result coming to commercial product is really not easy. So this is over the last 10 years I've learned. And in the middle, actually, we created this name called the sonomyograph. So some of you may know electromyograph, that is electrical signal generated by muscle during contraction. But the electromyograph has a limitation. That is, when you want to differentiate the signal from different muscles, it's very challenging because all the electrical signal will be combined when we collect the electrical signal from surface using electrode. The ultrasound, as all of us know, that we can see different muscle parts in our body, no matter is neighboring or is overlapped. So this actually makes us to think in 2006, and we create this name, and now this being more and more used and ultimately for. So the idea is that we use the muscle architectural change as an indicator for the muscle function, and that can be used for muscle control as well, like a prosthesis. And we are working on other control as well as a muscle assessment. Regarding today's topic, scoliosis, I think many of you may know this well, but I just very briefly introduce a little bit. So our spine should be lateral node deformation, okay? Anterior, posterior have the natural deformation. But unfortunately, around 5% of kids mainly during their adolescent stage, they will develop this disease called scoliosis. Since the reason unknown and happens mainly in adolescent stage, so this is what they call AIS, adolescent idiopathic sclerosis. Another unfortunate thing is that females' incidence is much, much higher than male. So around for severe cases is around 3 to 7. As all of you know, and I believe many of you are taking a lot of X-ray for scoliosis patients in your practice. So this is the golden standard, but we all know that the X-ray radiographer has 2 features. One is 2D, and second has radiation. Even though we recently have the low radiation device called the EOS system, okay, but still have radiation. But anyway, this is the golden standard. But How about the other devices? Many of you are operating MRI and CT. Now that can be used before surgery, but normally will not be routinely using for scoliosis assessment. The reason is the posture, and certainly cost and time, other things, but mainly the cost, the posture. But we do have some other methods, simpler method, that is a surface topography. There are many different ways. But unfortunately, surface topography can only provide surface information, not internal information. And this is the beauty of all our imaging devices or medical imaging devices. So this is why at most it can be used for screening. But unfortunately, the treatment of scoliosis is mainly based on angle. The reason is obvious because we do not know the reason of the occurrence as well as the progression. So that's the only way is based on the degree, then determine what treatment technique being used. Starting from brace, and actually before brace, we can do the exercises. In Chinese, we can do massage, Chinese medicine. And ultimately, we need to do surgery. But certainly that should be avoided because once do the surgery, the spine will be fused. And there's a lot of effects. So X-ray has been continuously using from the very beginning. Remember, in the adolescent stage, kids grow very fast. And this is also why the reason we have this sclerosis. So in one word, there's a lot of X-ray need to be taken. But you may ask, just like earlier speaker just mentioned about the contrast agent effect. So similar X-ray has any effect or not? We know it has an effect but before 2016, there's no solid evidence what is the effect. But in 2016, a Denmark group, actually, they followed for 25 years for a group of subjects in comparison control. And they found 4.8 times higher cancer incidence, and mainly breast cancer and oral cancer. So that because of female issues. So this actually alerted the whole society. And I think particularly in Western countries, that the awareness is very high, as low as possible X-ray dose, because they know the effects there. How about ultrasound? Again, we all know that it is ionizing, that's non-ionizing imaging tools, and used so commonly in the medical field. And how about 3D ultrasound? Actually, 3D ultrasound mainly, as far as I know, 3-area fetus is one area, and another one is heart, but need a very special device. And the third one, nowadays we have device, is the breast cancer screening. Then for our team, actually, we starting from a very early stage, 2002, actually, we start to working on the 3D ultrasound imaging. So mainly focusing on the musculoskeletal, or in very beginning, the muscle. And for some reasons, that is really, in some way, very good today, because I come from biomedical engineering, actually my first degree electronics. So that is interdisciplinary. The reason is because in our biomedical engineering department, we have colleagues working with scoliosis, mainly for brace. The reason is because we are training 70% of prosthetics and orthotics in our program in PolyU. So because of this, we have colleagues working brace. And on the other hand, my ultrasound, starting from a very early stage, has been collaborating with orthopedics. We start from articular cartilage and bone, a lot of other tissues. So this is why I know there's a disease called scoliosis, but before that, I don't know. So this is the reason. Now we have technique and we know the problem. And starting from 2006, we got the first grant to working on this. So let me introduce a little bit details in this area. Try to control my time. And this is a B-mode image of spine, the cross-sectional view. And typically we can see there are spinous process on the top, and the two sides, some lateral features. If in the thoracic region, it is a transverse process. And now the main feature in this image, actually from our radiographer's point of view, is nothing, because it's a black region after the bone. So that is also true. So how we ultimately actually divide this device? let me show you the video showing how the spine being scanned from the bottom to the neck. So this is the whole scanning process, and you can see again a lot of the dark regions. Okay, and the most information may be coming from the bone and some muscle information, but we are interested in bone. So let's have a look. So the key is that we, in some way, creatively or crazily, actually think that we can image the bone using ultrasound, but it actually cannot, because when the ultrasound hits the bone, all the signal will reflect and leaving up all the shadows. And this is artifacts, as you have learned, okay, in school. So we developed this device. So the idea is that we stack all these images together in 3D. Because of this, we made a special probe. That probe can being tracked. So the location and orientation of the probe can be known. So because of that, we can stack all the image in its real position and orientation. And finally, we do a lot of image processing. In the very beginning, traditional processing, but nowadays we have more and more AI. I believe this is why we are invited, because today we are talking about smart radiography. So you later will see that we do a lot of deep learning for this project. So ultimately we form an image like this. So very surprisingly, when we apply the patents, some patents being processed almost for 10 years before they give us, because everybody think this idea is too simple. Okay, but the crazy thing is that we basically use some wasted information or distortion information and to form image. So on the right side, that is the main image. Later I will show you a lot. So in this image, what do we see? The dark region, that is the shadow of bone. But for some reason, we form the image like a X-ray image, and we can use that for angle measurement, the copper angle measurement. Okay, let me show you a little more detail. So this is how the image is being formed, and we are forming a coronal view image. But traditionally, ultrasound can only provide a cross-sectional view, transverse cross-sectional view. So as we going up, each image will get a very small portion of image, then put them together and to form this image. So you can see that we are gradually forming the whole spine. So for kids, around 20 to 30 seconds of scanning time. So this is how it's being formed. Now we can see that with this technique, we are able to form images for scoliosis kids with different severities, as we've seen here. And the main feature is the middle one is formed by the spine, okay, the bone in the middle. I suddenly forgot the name, sorry. A little bit nervous in front of all the experts. Yeah, spinous process, okay, spinous process. And the side one, and mainly formed by rib and also transverse process and other features. So you may ask, how about the accuracy? Okay, since we are providing a tool for clinical use. So we have done a lot of research, and this is our latest one after a lot of enhancement. So you can see almost 1-to-1. And remember, even X-ray, to radiographer to measure, they will have deviations. So the standard deviation is around this plus and minus 5 degrees. So therefore, that is in some way very nice. So now we have developed a lot of things, and this is one of them. That is automatic measurement. So now we can conduct automatic measurement completely and by deep learning. So in this model, we train around 2,000 images. And another thing, or the beauty of ultrasound, is that we can make it small. Because nowadays, I think all of you know that we have a palm-sized ultrasound scanner linking with a terminal like a PC or tablet or even mobile phone. So we now make this device very small, and the image can also be formed. Because of penetration issue, actually the image is a little bit blurred, and also because of the tracking sensor. In this portable device, the tracking sensor we use an optical tracking. In the bigger device, we use an electromagnetic tracking device. So remember, we are 3D. So therefore, not only radiation free in comparison to X-ray, but X-ray can only provide 2D. information. But ultrasound, after scanning, we have the 3D data. So because of that, we can do a lot of 3D information related visualization and measurement as well. Oh, sorry. So one thing we are working on is we are modeling, taking modeling, okay, for the 3D model. But remember, there's one part ultrasound cannot see, that is the dark region, the vertebral body. Because the ultrasound from the back, we cannot see the vertebral body. But unfortunately, for most of the scoliosis subjects, they at least can have one X-ray. Once they confirm their scoliosis, they will have one X-ray. So that X-ray can be used to fuse into our 3D modeling. And this is some other model you can see here. We are working on this area, all using AI. Without AI, we cannot do this, basically. So if you have not been thinking about AI, I think you need to think about that very soon. AI will go to your practice. Okay? So to scan, we also use robotic. So that is very straightforward, robotic arm, because I know many of the sonographers have fatigue, okay? So this is why we are thinking about that. If we keep scanning the whole day, that will be a huge problem. So this is why it's very natural. But one big thing that we are doing is prediction for progression, because this doctor told us that the holy grail in the field. Thinking about that, when we first diagnose a subject with 10 degrees, that is classified as scoliosis, and we can tell the parent and the kids, after 5 years, if you do not do anything, it will be how many degrees? Okay, so this is why we are working on this. And the reason why we think it can be successful is because using X-ray, they use the two-plane X-ray and model, the 3D model, and then from the 3D information, 90% of accuracy for prediction. Okay, so that's why we think we are providing 3D information and we can do this. Now, so far we have collected over 1,000 cases in PWH, and many of them already been followed by 4 years and some already 5 years. So this is very soon we should have the result. Again, AI, and this is in some way crazy. When my student first proposed this, I do not believe. Okay, show me the evidence. But now I start to believe, because we can actually convert the ultrasound coronal image into X-ray image by training. So this is something happening. Remember, this model only been trained with 150 data. And now we are working with PWH with 2,000 images. So I think the result will be much better. So in summary, so we are providing a device, and if you want to know more, actually the company has a booth there. You can have a look. So this is not like unreal, but actually real. Ultrasound really can provide all this. X-ray definitely is accurate, but it has many limitations. And other methods, they have their advantages, but they also have shortcomings. Particularly, cannot going through the body. This is why they cannot see what's inside. And then you may ask, okay, so what? You have this device, how it can be used? So according to our 10 years of exploration, and now the device has been installed in Europe, in Australia, in China, rapidly increased, and recently we got a registration in Thailand, and now working in Malaysia and Indonesia. Very soon, I think in the East Asia will install. So the idea is that because of its unique features, basically two unique features. One is radiation free, and second can provide 3D information. So basically we can cover the whole management cycle, starting from screening to follow-up monitoring, as well as a treat outcome. And we can provide much frequent imaging instead of X-ray maybe every year or at most every half year. And another thing, now our device in Germany, they are practicing one thing is during the subject being treated with the manipulation. So they use ultrasound to scan. So they to confirm the spine inside is really as what the trainer want to be. So that will be really, really helpful. And certainly the prediction, as I mentioned, we hope that we can provide very soon. These are all the installation in different places. And we are very fortunate. This Hong Kong company has been, got the first round of investment, and also device. We got the first Bank of China Innovation and Technology prize. Okay, the only one actually in that category called Health and Life. So there's a lot of awards we have won. Now I want to verify the device is really developed by us, not some corporate. Okay, so we have quite a number of patents. Actually, you can see starting from 2007 when we have the first prototype and gradually build. I really want to thank one of our the founder. He is an industrialist. Okay, and before the first round of investment, he and his company had put over 60 million Hong Kong dollar to bring research output really become a product. So this is the role. Actually, you can see if we count from our early research in 3D ultrasound is almost 20 years. And that is also why Hong Kong is so difficult to develop innovation and technology industry, because we need a patience. But in many cases, because of the historical reason, Hong Kong businessmen does not have patience. They want to have a quick money. So in case you or your friends have money, and persuade them to have patience. Okay, so these are patents that we want to file. And in some way, this is very strange because most of our research will simultaneously file patents and publish papers. But for this one, because the company is interested, so this is why we file patent more and to protect it. You may say it's totally for commercial reason. Actually not. We even file not only in China, but in major markets. The reason I want to share with you, because I learned something from the elasticity imaging. Some of you may know elastography. That field is fantastic in the very beginning because I was in the beginning when my PhD starts. But later I found that there's a problem because there are too many techniques. And also too many companies can make this technique and everyone say they are the best and make the conditions actually very uncomfortable. Therefore, up to now, only in some specific regions like FibroScan, the liver fibrosis measurement, majority of the area is not well utilized. Okay? So one reason is standard. So this is why from the very beginning, I'm thinking that I should file the patents, and fortunately the industry, the companies, they support us to file patents, and ultimately we have all these very intensive protections. So that is the main thing. So how about the future? As a company, they need to survive. So in addition to sclerosis, now they are thinking the whole body musculoskeletal tissues. So they are now develop a new device, and also for the surgery. And this year we got government funding and to use 3D ultrasound to guide some surgical procedure of the bone fracture in kids. So that mainly the elbow. Okay, so they will insert some pin and we want to guide the pin. So this is why that is for the surgical side. Now I think I may still have some few minutes. Okay, so I will stop here. I hope the chairman can allow me to take some questions because I still have time. If they do not have questions, I have 20 slides more. I can continue to speak. Later. Okay, let me continue. I want to use half of my time, okay? So you may say that, okay, what research you can do, have done to verify that. Actually, we have done a lot of research first to verify that. That is for reliability and the validity tests. So you can see we do a lot of inter, operator, rater, all the measurements. So the overall idea is that it is very repeatable. So this is why you scan once, scan second, then they are very repeatable. I do not go to details. This is another validation started in Netherlands. They are the first installment of us. And later on, we actually have a lot of progression study, as I mentioned. Okay, so X-ray, if above during the between the two tests, X-ray tests, if the angle change larger than 5 degrees, that is defined as progression. So if our ultrasound can detect similar thing, then we can do the progression monitoring. But as I mentioned, we want to do more for prediction using 3D information. And another thing is that we found that, oh, there's a coupling between the sagittal and the coronal view information. Remember, we are 3D. This is why by single scan, we not only got the coronal information, but also the sagittal information. So the finding is that for similar mild angle, if the kids have flat thoracic region, then these kids will progress. If the anterior posterior curve is normal, then less chance to postgraduate. And we can measure rotation as well. Because spine in the sclerosis, particularly severe sclerosis, the rotation is very large actually. And we can do the scanning in all the postures, any postures. So this is one of my colleagues actually working with brace. Before the brace design, they need to know the kids, the flexibility. So this is actually flexibility test under different postures. And this is the reason why CT and MRI is not commonly used for diagnosis for sclerosis. You can see that when the posture changes, the spine not only change in the sagittal view, but also the coronal view change a lot. And because of that, the reason is the gravity, because we standing there very different. And this is forward bending, similar. Forward bending actually is the screening method. But we do not know what happens when the kids forward bend. So we try to understand more about this. And how about in X-ray? I believe some of you know this. We will use different postures during X-ray, particularly for EOS, because they do not want to block the sagittal view. So, well, this actually affects the deformity? Actually, yes, but mainly affecting the sagittal view, not coronal view. So this coronal view is quite consistent. This is my last slide. Thank you so much.
The first speaker is Dr. Yan Tong. Dr. Tong is the clinical marketing and application specialist in Shanghai United Imaging Healthcare Company Limited. Dr. Tong studied in US, Texas A&M University for the BSc in biomedical engineering, and then studied in Oxford, England to complete his PhD in magnetic resonance physics university. Dr. Tong conducts research covering functional MRI, diffusion MRI, statistical parametric mapping, and mammalian green fluorescent protein reconstruction. He now focuses in developed advanced MR sequences and image post-processing methods for the key customers of the Shanghai United Imaging Healthcare Company Limited. Apart from the business, Dr. Tong has great talent in languages. He can speak English, Chinese, Spanish, French, German, and Turkish. Today, he will speak to us in English. And today, his topic to share with us is archiving the impossible for imaging, total body MR imaging at 5T. Please give a big hand for Dr. Tong.
Thank you. Thank you for the introduction, and good afternoon, ladies and gentlemen. It's a great pleasure to be here attending this event at this great venue. So I'll have an introduction on our 5 Tesla MR scanner. So I'll have 20 minutes to convince you that 5 Tesla is a great field strength, and this is where the future is. So if we look at the status quo of MRI, many of you would operate 1.5 Tesla and 3 Tesla scanners. They are the clinical routine, and they are our workhorse for our examinations every day. Apart from that, there have been a series of endeavors across the world to achieve or look at MRI at a different field strength. These include 4 Tesla, 4.7 Tesla, 7 Tesla, 9.4 Tesla, and so on. However, for whole body imaging, none of this field strength is clinically approved. So if we have to think about the future of MRI, and in reality, the field strength of clinical MRI has not changed for several decades, what is the next field strength? What are we looking at? So to answer that question, we have to first look at the challenges of imaging at a higher field strength. So if we want to image at a higher field strength, what are the major problems? So number one, we have image uniformity. So as the field strength increases, the RF wavelength increases in our tissue as well, thus resulting in shading artifacts, which is quite challenging at 3T even for abdominal imaging. However, according to our simulation, 5T has a great potential of providing higher SNR compared to the 3T images while preserving the B1 homogeneity. And according to our simulation, this is particularly beneficial if you compare that against 7T. I'll explain why we're able to achieve that in just a minute. Number two, we have the issue of safety. So in terms of safety for MRI, if you look at the RF, we're primarily interested in the SAR, or the specific absorption rate. So SAR is proportional to the square of the field strength. Therefore, going from 3 to 5 to 7 is particularly troublesome. According to our simulation, again, the local SAR at 5T can be reduced to by up to 80% compared to that in the 7 Tesla. So again, we think that 5 Tesla might be a sweet spot if you look at the comparisons against the 3T and 7T. In the end, why did we pick the 5 Tesla? There is a bit of a history in here as well, because if we look at the first prototypes of MRI, we have a 2 Tesla scanner as a prototype in the 1980s. So what we end up today is the 1.5 Tesla for our routine clinical work. We also had earlier prototypes of 4 Tesla MRIs. Maybe there are a couple, 3 or 4 in the world. However, we settled with the 3 Tesla MRI for higher field, and that's a clinical workhorse. At the moment, we do have 70 commercial offerings from several vendors. However, their clinical use is limited to the head and MSK applications. So we think that 5T could be the breakthrough of whole body ultra high field MR applications. With that, let me introduce the 5 Tesla scanner from Yantian Imaging. We have, of course, a 5T magnet with 0 helium boil-off. We also have a very powerful gradient system of 120 millitesla per meter of the gradient strength and 200 Tesla per meter per second of slew rate, which allows us to explore neuroscience with diffusion tensor imaging and functional MRI. Along with that, we also have 8-channel body transmit system. So that allows us for body imaging, for the abdomen, for imaging the abdomen, the pelvis, and so on, and the spine, which is not possible at the moment for 7 Tesla. We all know that space is precious in Hong Kong, and for the 5 Tesla scanner, it has very low sighting requirement. So generally, it can fit a 5T in a 3T room. We do have whole body clinical applications. And finally, we have the capability of doing multinuclear MRI and MRS. So why can we generate homogeneous images on the 5 Tesla, even though we know that abdominal imaging can be homogeneous even at 3T? This is because we have a unique 8-channel volume transmit coil enabled by our 8 independent RF power amplifiers. So these amplifiers allow us to play independently driven RF waveforms in each of these channels, and we can use this hardware configuration to achieve homogeneous excitation of our body. So if we look at the 3T and 5T image comparisons to the right, we can see that homogeneity is really not an issue for abdominal imaging at 5T. Coming back to the sighting requirements, we can see that earlier generations of 7 Tesla are very, very heavy. And in terms of the weight and the 5 Gauss line, actually, the 5T is very similar and comparable to the 3T. So again, generally, a 5T can be installed in a 3T room. So if you have a 3D scanner and you want it 5, that's probably not an issue. If we look at the clinical images, we do have a whole body application. So starting from neural, spine, abdominal, MSK, cardiac, and angiography and whole body capabilities. I'll spend a few minutes in just the coming slides to explain to you what it can do for you in each of the major anatomies. So let's start from the head. And this is a very, very interesting field in which 5T can bring you a lot of benefits. So the first thing we look at is TOF MRA. So here we have a comparison of the same subject scanned on the 5 Tesla and the 3 Tesla with the same acquisition time and imaging resolution. Very obviously, you can see that not only can we visualize more distal vessels, we can see them more clearly as well. So this is because we have more of a flowing effect with TOF, and we have a longer T1 at 5 Tesla as well. So we can see more than some distal vessels in the TOF MRI. Here's another example with 5T and 3T comparisons on the same subject. We can see more abundant LSA, or electrical striate arteries, on the 5T. And in the 3T, we can barely make out of them. Maybe you can see one of them, but in the 5T, you can see them much better with higher accuracy. So here is another example which shows what we can see with the 5 Tesla TOF image, which you cannot at 3T. So at 5T, using this example, we're leveraging the gain in intrinsic SNR at this higher field strength to visualize the shape of the arterial dissection, which is confirmed by our DSA examination as well to the middle, but this cannot be seen at the 3T images. We can also have high resolution T1 weighted 3D images to look at the arterial dissection and the fossa lumen, again, confirmed by the DSA. This is another example in which high resolution 5T images allows us to visualize the opening of the LSA, and you can see, as indicated by the arrows, the plaque at the MCA and infarction in the distal branches. In addition to routine anatomical images such as T1, T2 weighted images, one thing that is particularly beneficial at a higher field strength is SWI, or susceptibility weighted image. This is because not only do we have the gain in the intrinsic SNR brought about by the increased field strength, the susceptibility effect is also more pronounced at 5 Tesla. And that allows us to not only see the images with better resolution, but we can have a better contrast as well. So here we have, again, 5 and 3T comparisons on the same subject. With this even shorter spatial resolution, shorter scan time and the same spatial resolution, we can visualize the cortical venule expansion much better. We can utilize the increased SNR to gain higher quality images for diffusion as well. So here we have an example of extremely high resolution, which is 0.8 isotropic, enabled by our multiband or simultaneous multi-slice factors, a factor of 2. With this, if we reconstruct the white matter tracts, or what we generally call tractography, we can come up with these U-shaped cortical fibers, which are generally difficult to find at a lower field strength or lower resolution. The same can be said for functional fMRI. This is using a simple finger tapping task on both sides with a block of 80 seconds. So with 5 Tesla, we can use its resolution, use its SNR to gain high resolution. This is 0.8 isotropic. So we can see that the distribution of the activated areas or the activation regions in the deep cortex can be much better visualized compared to the low resolution image with 3.5 millimeter isotropic. Next, we can move on to the body, which again, at the moment, cannot be clinically imaged for fields higher than 5, namely 7. First, we can have a case of a kidney patient. So if you look at the image on the left, we have a a bright spot, possible lesion, but we cannot be sure. So this is routine resolution, slight thickness, and acquisition duration. We can, however, try to increase the matrix and thus having a higher resolution at 3 Tesla, which is the one in the middle. However, at this case, we are actually SNR starved. So you can see that even though we have higher spatial resolution in the middle, we cannot be 100% sure whether we have a lesion or not on the kidney. If we perform the same examination, again, on the same subject at 5 Tesla, we can be very positive of the lesion because of the SNR gain, and the boundaries are more clearly visualized as well. So this is something that can be really helpful to these micro lesions across the body if we scan on the 5 Tesla. Here is another MRA example, which is renal MRA. Here we are using inversion recovery based balanced SSP acquisition to look at the renal artery branches on 3 Tesla and 5 Tesla. As you can see, with better spatial resolution, we can see more distal vessels and better. In addition to SWI and fMRI, another imaging method that is particularly useful at higher field strength is MRS, or magnetic resonance spectroscopy. This is because not only do we have more signal, which gives us a higher peak compared to the baseline, we also have more spectral separation. And that means that at higher field strength, the peaks by the laws of physics are going to be farther apart in the acquisition. So here we have a prostate case. We all know that in prostate cancer, the metabolite citrate is very important. So with this case, we can see that on the 5T spectra, we have the split of the peak of the citrate peak, and this peak is actually a doublet. However, if you have 3T or lower field strength scanners, this may not be able to. You may not be able to see that difference just because of the limited spectral separation at lower field. We can apply similar experiences we had in the brain to the abdomen. Here we're also trying susceptibility weighted imaging in the liver. So we have a technique we call U-switch, which is essentially SWI in the abdomen. So here we have a 53-year-old patient with some post-interventional changes in the right lobe, and we also can visualize the portovein tumor thrombosis as well. The other thing we can do very well is MRCP. Again, none of that is available currently on our 70 offerings in the market, but this kind of examinations can be routinely performed on our 5 Tesla scanners with very high fidelity and resolution. Finally, for the body, we have some prostate cases for imaging the pelvis. This can be particularly challenging at higher field strength because of the limited penetration of the RF signal. However, with our 8-channel transmit system, we're able to achieve very homogeneous excitation and good uniformity in the T2 and T1 structural images very, very well. We can also do the same for EPI-based diffusion, and we can see some neoplastic lesions, which is also, again, sort of confirmed by the PSA value of this patient, which is 5.43. And in terms of imaging the lumbar spine, we also have some good cases of the patient being scanned on the 3T and 5T respectively with the same resolution. We can see that some of the details, particularly in the cauda equina, can be visualized very well, and we can have a better signal at 5T. Next, we can move on to cardiac. So cardiac imaging is something that I think you are very familiar with as radiographers. Many doctors and even radiographers prefer to scan cardiac on the 1.5T system. This is because of the challenges associated with the field strength at 3T. But with our 5T scanner, you can actually get very reasonable and great cardiac images thanks to the increased SNR and our 8-channel transmit system. So here is a comparison of sending images, and using this higher field strength, we can aim for a reduced higher resolution and also reduced slice thickness. So compared to a conventional 1.8 by 1.8 by 6, we're looking at 1 by 1 by 3. So here we can better visualize the muscle trabeculae and tendon cords in the heart, as indicated by the black and white arrows. The same can be said for dark blood T2 images, and also post-gadolinium PSR images, which show the subendocardium fibrotic structures on this particular patient. And finally, for these different anatomies, we're looking at our extremities. First, we have some MSK examples. Here, very simple case for proton density weighted imaging. We can see that the SNR is greater with the same spatial resolution and even reduced scan time. And this is another case in which we utilize the increased SNR to give us higher resolution, higher spatial resolution, which clearly displays the bone texture and the microscopic lesions for the image to the right on the 5 Tesla. And finally, we have a phase contrast based MRA in the extremities, in this case in the foot. So we have one on the left on the 3T and one on the right acquired on the 5T. So this is a very stark contrast, and in general, from our experience so far, MRA is really great at this new field strength. So this is our 5T scanner, and we're looking at an ultra high field future with advanced whole body coverage, advanced applications. Here are some few more topics that we do not have the time to talk to you about, including T1-row, arterial spin labeling, QSM, and APT-based or CEST methods, and also fat quantification and conscious cancer MRA, and so on. So the future is boundless. Currently, we do have 6 installations, and we have 2 more going on as we speak. We expect to have more by the end of the year. So with our installation sites so far, we've had quite a few papers published already. Again, we expect more to come in the coming months and years. One of them, which is particularly interesting, is the one maybe the second to the left, which is published on Radiology earlier this year. And this is a very interesting customer who has access to the 3T, 5T, and 7T scanners. So they had a comparison of TOF MRA on these field strengths. So I think it's very interesting. And if you're if you had any interest, please have a read of the paper. So that's all of my presentation. And
let us introduce the 4th speaker, Mr. He. Mr. He is studying in the Hong Kong Polytechnic University as a PhD candidate in HTI department. He received his BSc in Central South University, which is a Chengsha GBA, and MSc in City University, Hong Kong. He worked for ASTRI before as an engineer for medical image analysis, optical coherence tomography, segmentation, and lesion detection. His publication covers COVID-19 chest infection images, artificial intelligence in digital pathology applications. His main interest now goes to object detection and segmentation in medical images. Today, he will share with us on the topic, deep learning-based differentiation of COVID-19 and non-COVID-19 infection cases, and segmentation of COVID-19 infected regions in chest X-ray images. Let's welcome Mr. He.
Hello, everyone. I'm He Zebang from the Department of Health Technology and Informatics, the Polytechnic University, and I'm the PhD candidate. Today I will have my presentations about the deep learning-based differentiation of COVID-19 and non-COVID-19 infection cases and segmentation of COVID-19 infection regions in the chest X-ray images. While my major subject is the development of the artificial intelligence techniques, and it's appreciated for me to receive the experience from the medical experts. Thank you. Okay, first of all, I will introduce the contents of my presentations, including the background knowledge, the aims and objectives of our research, the methodology in our studies, the experience in the differentiations and segmentations, and the experience results. The final part is the discussion, significance, and the future work of our work. First of all, let me introduce some simple background knowledge about the deep learning and the COVID-19 infections. As we know that the COVID-19, which is called the contagious disease caused by the SARS-CoV-2 virus, which is the most threatened in the recent years. Although the COVID-19 has already gone, the experience of us to use the automatic technology to fight against with it is the valuable experience when we face the pandemic again. In the COVID-19, in the fighting against the COVID-19, we found that the highest efficient methods to diagnose and monitor the disease progress of patients is needed, while with the shortage of the radiologists and doctors. And then we find that the chest X-ray is a good way to monitor the disease progress for treatment and evaluate the therapy efficiency. Therefore, our target for applying the automatic technologies in the chest X-ray is to accurately segmenting the COVID-19 infection regions from the chest X-ray images. And next, let me introduce some radiographic findings of COVID-19 in chest X-rays, which we will use for the artificial intelligence. It includes the reticular patterns, ground gas opacities, consolidations, and the combination of these phenomena. Okay, and next is that why we choose the chest X-ray as the imaging modality used in the AI technologies is that the radiographic findings are very easily to find in the chest X-ray images, and it's also easily for the deep learning networks to find the infected regions and show to the doctors or show to the radiologists. And moreover, it's very easy for the radiologists to annotate these infection regions for the network to learn. That these two reasons leads to the popular modality in the chest X-ray as the AI technologies. Therefore, various deep learning algorithms which want to segment the infection regions from the chest X-ray slides are proposed, and with the less cost of the manpower and automatic workflow, this works make rapid progress in the COVID-19 disease diagnosis assistance and other applications. However, this application has a very serious problem that all the majority of these works are assumed that the input X-ray slides with the COVID-19 infections. However, in the real medical scene, is impossible, while some cases may have the infection, while some cases may have non-infections or the non-COVID-19 infections. Therefore, there is a very big problems of the data mixed with the COVID-19 and non-COVID-19, that if the COVID-19 infection and non-COVID-19 infection images are mixed in the input of the deep learning models with the similar radiographic findings, the deep learning models will be very difficult to divide and further influence the performance of the assist diagnostics. Therefore, before we segment the infection regions of the COVID-19, we need to make a preset of the differentiation between the COVID-19 and non-COVID-19 infection, or even the normal slides before the segmentations. And then we will have two pipelines in the recent work which wants to do this differentiations and segmentations. First of all, they will start by the classification models, which wants to find out the COVID-19 slides first, and then apply the segmentation on this COVID-19 slides. And secondly, and they will apply the segmentation first to find out the infection line regions, and then apply the classification models to identify if these infection line regions are the real COVID-19 regions. However, for these two pipelines, they will also have some problems. First of all, for the type 1, which apply the classification models first, while the segmentation is highly depending on the classification, while the classification is also based on the whole images because it is the step before the segmentations, and the classification is applied not in the affected areas. Therefore, the performance of the classification has its limitations, while it will further influence the performance of the segmentations. And for the pipeline 2, which apply the segmentation first, while the segmentation could only find out the high probability regions, which we call the infection line regions, they will also have the problems that the COVID-19 and non-COVID-19 infections, like the viral or bacteria phenomena, may also have the similar radiographic findings. Therefore, the actual classification could not perform the effect as the precept to differentiate the inputs and make the classification step has less meaning. Therefore, we call the two problems of current pipelines that the classification is not applied in the effective area, and the classification could not perform as the precept to differentiate the input first. We have proposed some solutions that for the effective area, we will use another type instead of the infection-like regions. In our work, we choose the lung regions, which is also easily annotated regions. And for the second problem, we need to use the result of the classification as a filter of segmentation before we will have the two solutions. That first, we integrate the classification into the segmentation pipeline, and then use the classification result as the gate functions to filter the segmentation. And then we will briefly introduce the aims and objectives of our research subjects. Our aim is to develop a new deep learning algorithm for automatic chest X-ray differentiations and infection segmentation of COVID-19 regions by utilizing the lung region information in both tasks. And then our objective includes to design the deep learning pipeline for differentiations, to extend the performance of our new pipeline, and to solve the problem in medical practice for segmenting COVID-19 infections, while the COVID-19 and non-COVID-19 infection are both exist in the data. And then we will introduce some details of our methodology. First of all, we use the public available data set, which called the COVID-QUES data set, to apply in our experience and never designed. It includes 5,826 chest X-rays, and they also provide the lung region mask for us to develop our pipelines. And there's also some samples from this data set, which is shown in the slides. And then we will briefly introduce the networks used in our the framework used in our network designs. And the input chest X-ray images will be fed into the feature extractor to extract the general features of the chest X-ray images. And then the general features will fit into three lines parallelly. The first line is this line, the differentiation line. It will output the result of the identification that if the images are COVID-19 infections, this result will be treated as the gate functions to let the infection regions output normally. And if the differentiation result is a non-COVID-19 and normal, and the gate function will control them to output a blank infection mask to avoid the false segmentations. And then the lung region information, which is in the middle line, will be control the result of these two lines, which is lung infection segmentations. And in the first line, and the differentiation in the third line, as the attention mechanisms, and then these two lines will receive the information of the lung regions and output their corresponding infection regions mask and the differentiation results. Moreover, we also apply the novel design collaborative attention mechanism, which used in our models. And the information of the lung regions will generate the cause information first, which is shown in the first line. And this attention will hint the whole lung regions. However, as we know that the infection region is not fully equals to the lung region, so this attention is a cause attention. Therefore, we need to refine the attention by integrating the lung region and the infection regions together and get the refined attentions after the collaboration and enhancement, and get the final reason get the final attention using the differentiations and infection segmentations. And next, I will briefly introduce the loss functions using our pipeline in the very fast. Our loss functions contains 3 parts. The first classification loss, which is the multi-class cause entropy loss, and the second loss is the supervision loss for the lung regions, which is the binary cause entropy multi-scale loss, and the final loss, which is the most important loss, the infection loss, is the combination loss of the binary cause entropy loss, the intersection over union loss, and the structural similarity measurement loss in the multi-scale format. And the next, to validate the performance of our framework, we design some experience and show some results. First of all, we follow the official division of the data set and provide the data used in our experience. And the data formats, which is shown there, while the normal images and the non-COVID-19 infection images will have no COVID-19 infections, but the networks also need this mask as the reference. So we need to add the blank infection mask to these 2 types of the images for the stable training of the framework. And then this is some experience details for our framework in the design and the experience. And the next, the evaluation target of the experience include 2 things. The first is the differentiation of the COVID-19 and non-COVID-19 and the normal images. In this part, to consider the common sense of how to differentiate the COVID-19, we will use this pipeline as the step of how to differentiate the images. And the next part is the echo segmentation of the COVID-19 infections in the COVID-19 slides. And we will use the metrics used in the medical segmentations to evaluate the performance. And there's some evaluation metrics in the differentiations, including the accuracy, the F1 score, the Matthew coefficient metrics. And we present some results of our differentiation, differentiate the COVID-19 slides from the all slides, which is mixed with the COVID-19, non-COVID-19, and normal images. And we can see that our model outperformed in the differentiations between the slides and with and without the COVID-19 infections. And then we also perform the evaluation in the segmentations using these metrics, including the dice coefficient, the intersection over union, the mean absolute errors, and the saliency F score, which is widely used in the segmentation task. And then we also present the segmentation results in the set of the validation and testing. You can see that compared with the other models, our model gets the best performance. And this best performance also exists in the testing set, and which proves that our framework of design by integrating the lung region information together with the segmentation and differentiation get the high efficiency. And to have visualized results, we also show some segmentation results. And this segmentation result shows that our model could avoid the wrong segmentation of the infections and also have a more accurate segmentation in the actual infection regions. And the final part is the discussion and significance and future work while the COVID-19 has ended. First of all, our model has get the best performance in the idle sense when all inputs are with the COVID-19 infections, which is also the same assumption of the current deep learning algorithms. And the next part is that our model are also get the good performance in the differentiation, which proves that the integration of the lung region information could provide the more effective information for better differentiations and segmentations. Okay, and you will have another problems after the COVID-19 has gone. That if our models could only apply in the COVID-19, and the result is not, because we called our assumption that we will use the infection regions are in the lung regions. This is assumption of our framework to apply, and we only use the COVID-19 data set as examples. And for all the data which fulfill these requirements, they will also use our pipeline to apply in the differentiations and segmentation the infected regions. And it even do not limit it in the chest X-rays, because we have already published this verse, and we also use the CT images, and this pipeline is also work and even get a more better performance. Therefore, we will also have some future works, including that while the COVID-19 is gone, they will have some data which only has the existence of the COVID-19, and with the support of the data, we want to develop our framework to the multi-class classification and segmentations, which could differentiate more effective, like the virus and the bacteria phenomena. And we also want to develop a user-friendly platform which could use in the maybe the server or the clusters for the more friendly use, while our framework currently is also the deep learning platform and not apply to the ensemble device. Okay, and that's all the contents of my presentations, and very thanks for your listening, and it's my appreciation for attending this conference. Very thanks.
Thank you, Mr. He.
Thank you, all speakers. Because all of the speakers can attend the live, because all the speakers can't attend the live Q&A sections today. Sorry for no live Q&A sections. If you have questions about the talk, please send to the email info@hongkongra@gmail.com. Yeah, you may see it on the screen for the the blue ones. Okay, info.hongkongra@gmail.com. I think you have so many questions about the new technologies. They are so amazing talks for to date. Okay, I will redirect the questions to the speaker respectively, and they will reply you accordingly. Okay. Now, can you the panelists can stay here, and we want to take a good photo again, because now is so many participants and the panelists here. Okay. Well, are you ready to take photos for us?
Yes.
Okay. Could all the panelists and the participants can open your camera? now. Will, are you ready?
So let's stop share.
Okay. Could all the attendants or participants can open your camera? We take a full photo now.
I'm ready now.
Okay, we say hello. Are you ready? Okay, 1, 2, 3, smile. Get it? Well, Will?
Once again.
Okay, once again. Okay. We smile
Once again.
and
3,
okay,
2, 1. Smile, smile, smile. Once more.
Okay, great.
Thank you.
All right.
Okay, thank you. Thank you of you. Okay.
Thank you for the wonderful presentation today. It's a really interesting one on the whole body MRI and the COVID. The research work is very good.
That's
topic.
fantastic. Yeah.
To hear that details, we'll get in touch soon. Thank you. Congratulations to the entire team and the speakers.
Yeah, very good. Because the scleral scan is a very amazing invitation for the innovation of the ultrasound. Yeah, the new way for the ultrasound. Yeah.
Thank you. Thank you.
Okay. Okay. We want to promote the next year ISRT. You can see the postcard in your notes. Before the end of the program, I want to introduce the ISRT will be held in Hong Kong in next year, from 6th to 9th June of 2024. The details can go through this link. It's www.isrthk2024.org. Okay. And we will send the information for all panelists through their email. Hope you can join us for the biggest radiographers congress over the world and enjoy the delicious food and scenic in Hong Kong. Now we invite
so nice to hear. Thank you. Thank you for the invitation extended to all.
Yeah, hope you can join us and see you in next year. Yeah, in Hong Kong.
Sure.
We'll try to go. Hong Kong has hosted many times.
Yeah,
I have attended many times ISRT Congress in Hong Kong.
Welcome, Mr. Chen. I hope you.
So
I hope see
I'll
you
save
soon.
enough money to go next year.
Yeah. Okay. Now we invite Hong Kong RA Chairman, Mr. Nelson Vance, for the closing speech.
Yeah, thank you, Mr. And thank you all of you for joining us tonight. And I sincerely hope you all have a wonderful and fruitful lecture. And I think you can see how smart we are, right? So I also want to net these opportunities to thank Mr. Marco Lam from the MRTA, the VART for the organizing and technical support for this Asian CPD program. And thank you very much and see you in the next event. Thank you.
Okay, thank you, Chairman.
Thank you. Advance congratulations to the entire team. It's our pleasure to be there.
Thank you, Fabi.
Thank you.
Thank you. And before the end of the program, I want to introduce the next Asia CPD program, which will be hosted by the Palestine on 15th September 2023. Don't miss it and see you again. Okay. Good night, everyone. Good night.
Okay. Bye-bye.
Bye-bye.
Bye.
Good night. Thank you, HART, for a good
Enjoy.
lecture.
Happy weekend to all.
Okay.
Okay. Good night to all. Have a nice Sunday tomorrow.
Bye. Good night.
Good night. Happy weekend.
Good night.
Same to you. Good night.
Waiting to come to Hong Kong during ISRT.
Yeah, you're welcome.
Welcome. Yeah.
Thank you. Thank you.